Hello, and welcome to the Clinical Care Options and Global Medical Education Psychiatry and Neurology podcast. I'm your host, Dr. Prakash Masan. Today's episode features Dr. John Kane, Chairman of Psychiatry at the Hofstra Northwell School of Medicine, and Dr. Rebecca Roma, a psychiatrist in Pittsburgh, Pennsylvania. They will be discussing the relationship of extrapyramidal syndrome, Antiparkinsonian drugs, and tardive dyskinesia. This episode is part of a larger educational program titled Tardive Dyskinesia and Psychiatric Illness. For more information on Dr. Kane and Dr. Roma, along with links to other TD programs, including other podcasts and clinical thought medical commentaries, please visit the show notes. Now let's get started and hear what the experts have to say about this important topic.
I'd like to welcome everybody. Thank you for joining us. And Rebecca, great to see you. So we're going to talk about extrapyramidal side effects and tardive dyskinesia. And obviously this has become, I think, an important issue for several reasons. One is we're seeing, more widespread use of antipsychotic drugs across different diagnoses. We need to consider the risk of extrapyramidal side effects, the risk of tardive dyskinesia, et cetera. So Rebecca, what's your perspective on this? I mean, how frequently do we see EPS and TD, and are there differences between the medicines that we use?
Privileged to be working with you. Thank you. And my perspective is that this has become a hotter topic because now we have treatments for tardive dyskinesia. In the past, it was kind of a subject that we didn't really talk about because clearly it was caused by dopamine receptor blocking agents, and yet we didn't have anything to do about it. So, I'm in clinical practice, and I think it really depends upon your clinical setting, how often you're seeing tardive dyskinesia in particular. EPS and tardive dyskinesia, it used to be thought were only caused by first generation antipsychotics. But as second generation antipsychotics began to be used for more and more diagnoses, like you mentioned, whether it's adjunctive treatment to a mood disorder, whether it's, agitation due to brain injury or due to dementia, we're seeing more and more EPS and tardive dyskinesia.
Absolutely. I mean, I'm sorry to interrupt, but just, along those lines, it's been striking to see that only about 11% of the antipsychotic prescriptions are for people with schizophrenia.
Absolutely. Well, it used to be schizophrenia and bipolar disorder, and now it's anxiety, it's insomnia, it's you name it. So I still think that tardive dyskinesia, of course, and even EPS is more frequent with the first generation antipsychotics. But, there was a recent meta-analysis that was performed that looked at incidence. So with first generation, it's about 30%. So 30% of people will develop TD. If they're on a second generation and they've had past exposure to a first generation, that's about 21%. And if you've only ever been on a second generation, it's about 7%.
Yeah, and those prevalence figures, although they've come down somewhat, as you said, I mean, it's still a risk even with the second generation drugs. And if we look at the incidence, the number of new cases per year, it looks like, with the older drugs, it was running around 6%, maybe 6.5%. And with the newer drugs, it's maybe down to, 2.5%. So definitely a reduction, but it hasn't gone away. And I think there are some of our colleagues sometimes think, it's gone away. This TD doesn't exist anymore.
Well, I also think that, like we've been saying with the use of antipsychotics for so many different diagnoses, now all of a sudden, you have a whole new population that is at risk for tardive dyskinesia.
And also the EPS hasn't gone away either, even though the second generation drugs are less likely to cause EPS in general. There's still differences even among the second generation drugs. Some are more likely to cause EPS than others, right?
Absolutely. Absolutely. And I think that also, as practitioners, we need to take into consideration the risk factors of the patients that we're prescribing. So I think the biggest risk factor is probably age. Um, but you really have to look at not only the drug, but at who you're prescribing it to and be able to really differentiate between EPS and tardive dyskinesia.
Absolutely. So, I think the examination is key. And, one thing that I would emphasize is some patients who have never been treated with an antipsychotic drug, particularly elderly people, may have some abnormal involuntary movements before they ever receive an antipsychotic drug. And even some patients with schizophrenia. I mean, we've seen some young patients who have what appears to be almost extrapyramidal in nature before they ever get an antipsychotic drug. So, we really strongly recommend to clinicians that they examine the patient carefully before they give an antipsychotic, because it would be a shame to attribute abnormal movements to the medication when in fact the patient had it before. And I emphasize, particularly in elderly individuals, the incidence or prevalence of these abnormal movements that pre-exist exposure to antipsychotic drugs is not trivial, particularly in people who wear dentures. They may have difficulty with ill-fitting dentures, and so they've got some tongue movements, things like that. But even there are these so-called spontaneous dyskinesias in the elderly that we see. So emphasizing the exam is important even before you prescribe the drugs.
Absolutely. And you see it a lot in patients with autism as well. So you see a lot of tics, but you also see a lot of EPS or extrapyramidal symptoms. And so it's really important to get a baseline. So my recommendation to clinicians and what I try to do is to do sort of an abbreviated examination with every encounter. And in a high risk individual, we should be doing an Ames evaluation every 6 months. And with lower risk individuals, we could probably do it every year. But as you're saying, getting that baseline level before we even start an antipsychotic is extremely important. But it's hard as practitioners because when we see a new patient, they might come to us not on antipsychotic medication, but it's really hard because of the fragmented nature of the healthcare system to get a good history. So I've seen people with TD who swear up and down that they've never been on an antipsychotic, but maybe they were in a hospital situation, they were agitated, maybe they were in a rehab facility or some kind of detox, were agitated, received Haldol, and they weren't even aware. And now they have TD, and it's really hard to get that history to be able to tease out, okay, is this tardive dyskinesia? Is this EPS? Is this something that's already there? And you can see the same syndromes sometimes coexist, which is a challenge.
Yes, absolutely. Particularly the older individual, we can sometimes see TD and Parkinsonism, and that can be confusing because we know that the ideal treatment is different for those two conditions, right? For Parkinsonism, we're going to use an anticholinergic agent, but that might in fact worsen TD. So that differential diagnosis becomes really important. And as you said in the beginning, now we have FDA approved medicines for the treatment of tardive dyskinesia, which we really didn't have before. So that kind of emphasizes the importance of getting the diagnosis right.
And I think that that's a challenge when we haven't been used to, we sort of got away from Ames examinations as we got away from first generation antipsychotics. And as you're saying, if someone's on an anticholinergic, that can actually exacerbate their tardive dyskinesia. And the VMAT2 inhibitors that are used for tardive dyskinesia can potentially worsen Parkinsonism. So what do you do in a patient that is exhibiting both EPS and TD?
Yeah, so hopefully we can reduce whatever is causing the EPS. I mean, that tends to be a more acute phenomenon, and if we can reduce the dose of the offending agent, that can reduce the Parkinsonism. Whereas with tardive dyskinesia, reducing the dose doesn't necessarily improve the condition. In fact, it may transiently worsen it. So we want to try to eliminate the Parkinsonism and then treat the TD. I think that is a challenge. But as you said, I think the key is the examination too. And as you said, recommending the AIMS. And, people are now wondering, can I do the AIMS using telemedicine? And I guess I would emphasize a couple of things there is, yes, you can, but you don't want to focus just, on the orofacial movements, because what we've seen is that, about a third of patients who have TD don't necessarily have manifestations, in the orofacial region. So you do need to look below the head and neck as well. It may not be quite as easy to do that with telemedicine, but I think it still is possible. You just have to keep that in mind. And I think as the pandemic hopefully recedes, we'll be able to see patients in person more and make those examinations a little bit easier. But it's still it's not impossible, to do an AIMS exam even with telemedicine.
Absolutely. Now, what I've found in talking to CMHCs is many of them throughout the pandemic have only been using phone calls because patients oftentimes have not very reliable internet service. Maybe they have no internet service at all. Maybe they might have phone minutes. They might not have phone minutes. So this idea of phone calls is somewhat problematic.
Yes, that's a good point. Absolutely.
It's not a replacement for a virtual televisit. So to call a phone call telepsychiatry is really a misnomer. So what I do, because I do have a few, especially older patients who are very uncomfortable with any kind of platform, even if it's FaceTime. And what I do is I've been asking questions about movements. So as a screening, do you notice any abnormal movements? Do other people notice any abnormal movements? It's really important because these movements affect people's social well-being, their emotional well-being, their physical well-being. They're having difficulty, conducting ADLs. So these are the sorts of screening questions. And if there is any positive response to any of those screening questions, then I make sure that I'm either able to see that person face to face, or that at least we can set up a video chat so that I can do a proper AIMS.
And you emphasize the importance of trying to get the perspective from the family or other people who are observing the patient, because sometimes the patient isn't even aware of the abnormal movements until someone else points it out, right?
Absolutely. I had a patient just this year who she came back to me from a partial program. She had been in a partial program about 8 months, and they had put her on an antipsychotic. It was kind of a stronger dopamine receptor blocking agent. She came back to me, and this is someone I had treated for 3-4 years. And she very definitely had tardive dyskinesia, movements of her tongue, of her lips. And I asked her about it, and she said, oh, that's just something that I do when I get anxious. And I'm like, no, wait a minute. I've known you for a long time. You have never done this before. And we, eventually got her on medication. But not only are patients not aware, but sometimes they make excuses for it, or they don't realize that it can be a side effect of their medication. And they're like, oh, well, it's like biting my nails.
And there are other potential causes of abnormal movement. So, let's talk about that for a minute. I mean, earlier we talked about spontaneous dyskinesias that may be seen in the elderly, but, there are other conditions that can produce abnormal movement. So, we need to think about a potential differential diagnosis. So first, as you said, we should use the AIMS, and we should kind of apply criteria. Are there two mild movements that are present, or there's one moderate movement that's present, and has the person been exposed to an antipsychotic medication for at least 3 months, or if it's an elderly person, a month may be enough to cause tardive dyskinesia. Have they taken other drugs that are dopamine receptor antagonists like metoclopramide? But we want to rule out things like, Huntington's disease, Wilson's disease, Parkinsonism, essential tremor, Tourette's disease, hyperthyroidism. Wilson's disease is something that's treatable, so it's uncommon for us, but it's something that we certainly don't want to miss. So that's a condition that can cause choreiform movements and marked rigidity and dystonia. But you can do a lab test. You can do a serum ceruloplasmin, and you can do looking for the copper transporter gene, et cetera. So we do want to keep in mind the differential diagnosis. And it's important, as you said, to do those exams and to make sure we get input from other observers if we can.
Absolutely. Sometimes other observers can help you if you're in a virtual setting. They can help, position the camera so that you can see people's arms, you can see people's legs. And when you're going to do an Ames evaluation, especially in a virtual environment, you want to prepare your patient first. You want them to be sitting in a chair without armrests so that you can, in fact, do this examination, whether it's in person or what, because it's so important, because it really affects people's daily lives. It's interesting. I was thinking about, we were talking about when there's EPS and when there's tardive dyskinesia in the same patient, and how we would like to try to lower the medication to reduce the EPS, which then can sometimes unmask latent tardive dyskinesia. Or we could try to switch the medication. But in a few cases, you really have to, try to balance the use of an anticholinergic and a VMAT2 inhibitor, unfortunately, because there are some people that only respond to whatever medication and whatever dose they're on. And it really is a balancing act.
Absolutely. Yeah, and let's talk for a second about, what do we do when we have made the diagnosis, or at least the presumptive diagnosis of TD, and now we want to treat that person, because as you emphasized earlier, TD is something that can really interfere with psychosocial and vocational functioning. You think about somebody in a social situation, they're trying to get a date or something, and they have abnormal movements. It's not going to, make it easier to socialize. Or they go on a job interview, and the interviewer may not even sort of be aware that they're reacting to some abnormal movements. They just have a sense, well, there's something odd about this person. I don't, makes me uncomfortable. So, we really have to try to reduce these movements. And so the first thing that people think about is, well, what if I reduce the dose of the antipsychotic? Is that going to do it? Not necessarily. Or what if I switch to a different medicine? Suppose, they're on one medicine, I switch them to another medicine that maybe has a lower risk for TD. And even if we try to discontinue the medicine completely, sometimes that's helpful, but sometimes it's not. And for somebody who has an underlying condition that really needs an antipsychotic drug, we're not going to discontinue the medicine. Some people in the past have switched to clozapine, particularly if it was moderately or, severe assessed. And I'm a big fan of clozapine, but if somebody doesn't need clozapine for other reasons, now we have 2 medicines that are approved for the treatment of TD. So, we don't really need to go to clozapine.
Absolutely. And, it's interesting because I think, again, when you talk about screening, it's very important that even if these movements are subtle, we're able to catch them early, because once they've really set in, it's like you're saying, even if you reduce the medicine, even if you stop the medicine, even if you switch the medicine, sometimes the TD can get worse. And so screening all patients who we have on antipsychotics, young, old, risk factors, no risk factors, is the only way I see to be able to see mild movements. Because perhaps if we catch it when it's mild and treat it, Or even when it's mild, if we lower the dose or switch the medication, we are more likely to have success controlling those movements than once it's gotten moderate to severe.
Yeah, absolutely. And I want to just add one other point. When we think about risk factors, you had mentioned earlier older age, but another risk factor seems to be the early occurrence of Parkinsonian side effects. So if I have a patient who's developed an acute dystonic reaction or rigidity or akinesia or things like that, it really appears, or even akathisia, it really appears that those patients are at a higher risk for subsequently developing TD. So if we see patients like that, we want to try to eliminate the drug-induced Parkinsonism as much as we can, but we also want to keep, I think, a particularly careful eye on those patients because they may be at significantly greater risk for developing TD down the road.
Yeah, there are other risk factors as well. There are risk factors like comorbid substance use is a risk factor for developing TD. Also, intermittent exposure to dopamine receptor blocking agents is more of a risk factor. And we know with our patients, they're starting and stopping their medications all the time. And that is more of a risk factor for TD than just staying on an adequate dose of an antipsychotic.
Absolutely. And when you say adequate dose, I mean, we do want to emphasize trying to, use a low dose. It's always hard to identify the minimum effective dose because we're titrating against relapse. That's the only way we know we've gone too low. But still, there are guidelines, there are studies that have been done that suggest that we can keep doses within a sort of modest range, and hopefully that can also reduce the risk.
And aim for monotherapy as opposed to multiple antipsychotic agents.
Absolutely. And let's talk about the new treatments that are available. So, I mean, that's been an exciting development in the sense that, we'd gone for many years without an approved treatment. People were using tetrabenazine, which had been approved for Huntington's disease in about 2008. But a few years ago, in 2017, we saw the approval of two VMAT2 inhibitors, and so that was really good news. And what's your impression so far about those treatments?
So my impression has been that all of a sudden it's easy for us as mental health practitioners to treat a side effect that our medications have caused. Prior to this, I think that many psychiatrists, many providers would refer to neurology. And what would neurology say? Neurology would say, stop the antipsychotic. And we can't stop the antipsychotic because these are life-saving medications. So having a VMAT2 inhibitor, it works extremely well and extremely fast. So if you think a patient has TD and you start them on a VMAT2 inhibitor, if it gets better, guess what? Your diagnosis was correct. It is TD. So my impression has been very favorable. In fact, I've had, peers say, how do I use these? And I'm like, it's easy because you don't have to alter their underlying life-saving antipsychotic medication. The beauty of it is they can remain on their current treatment.
That's a very important point. Absolutely. And so the studies were done in patients, many of whom were taking their antipsychotic medication, and both valbenazine and tetrabenazine showed really very important effects. I mean, good effect sizes ranging from 0.6 to 0.9, and so both of these drugs are approved. Valbenazine is once daily dosing. Tetrabenazine is twice daily dosing, but certainly both an improvement over the tetrabenazine that people had been using kind of off-label. And the studies, I think I was very impressed with the way the studies were done. Very, very carefully. They have long-term follow-up to show that the improvements were not only sustained, but over time, when patients were followed for up to a year, let's say, the improvements continued. And one thing to keep in mind is that when the drugs were discontinued, some of the symptoms come back. So it means that some patients are going to have to take these medicines over a prolonged period of time.
Exactly. And I think that, the jury's still out on questions like, okay, if we start the VMAT2 inhibitor early, does that change the course of tardive dyskinesia? Or are these patients going to have to be on lifelong VMAT2 inhibitors? These are questions that I think are going to be researched in the future because we don't know the answers. We only know the studies that were done, which, as you mentioned, were very well designed and robust results, not with all patients, but with some patients, and really adds to things we can do to help our patients.
Yeah, absolutely. And, I think, as you said earlier, when there were no effective treatments for TD, people were kind of less likely to focus on it because I think we always have a hard time, making a diagnosis that we can't treat. So now, hopefully people will be more proactive in examining their patients very carefully. And there are some patients who are getting antipsychotic drugs who may not really need them. I mean, we talked earlier about, it's the only 11% of people with schizophrenia now. So, we have to remind our clinicians that antipsychotic drugs should only be used in patients who, where they're really indicated and really helpful. And when they are used, we have to keep an eye out for tardive dyskinesia because it's definitely a risk factor. And since so many more people are getting antipsychotic drugs, then obviously we're going to see more cases of TD. And some of the patients are being treated with antipsychotic drugs by their primary care physician. And they're not necessarily seeing a psychiatrist, as we would probably recommend, at least periodically. What's your take on that?
Absolutely agree. Absolutely agree that I think that as there are more second generation antipsychotics, more and more, primary care physicians are starting antipsychotics. There's a big push because there's such a shortage of psychiatric care. And I think that in particular, where we've seen the most growth of use of antipsychotics is adjunctive treatment of major depressive disorder and in bipolar disorder. It's kind of sad to say that it seems like the use of lithium is going down because you don't have to get levels with antipsychotics. It seems so much easier. But you're right. That leaves more and more people exposed to potentially getting tardive dyskinesia.
And some of those people, are have jobs and are functioning at a high level, and if they develop TD, it can really have a tremendous impact.
Absolutely, because it's like you said already, John, your first impression of a person or that sort of gut feeling is so important in the professional setting. And you're right, seeing someone with abnormal movements is just sort of unsettling, even if you're not cognizant that you're seeing those movements.
So, I think everybody, should learn how to do the exam. The AIMS exam is a pretty simple one that can be done in just a few minutes. And, what I've found is it can be sort of just woven into a routine session with a patient because you're observing the person as they come into the room, as they sit down. They may be distracted. You can see if there are movements. We know that sometimes if we can distract a patient, that movements will be more apparent. So learn how to do that exam. Learn how to weave it into your regular assessment with a patient. And we talked about telemedicine and the challenges and opportunities there. And then keep in mind that we do have treatments, and that TD can present in a lot of very sort of unexpected ways. I mean, we think of the sort of the prototype is the orofacial hyperkinesia, but TD can affect the trunk and the limbs and even the toes. And even the diaphragm. So it can present in very kind of unexpected ways. And
any muscle group.
Yeah, really any muscle group. So we need to, be sensitive to that and understand. And as you said earlier, some patients will dismiss it saying, yeah, I'm chewing gum or something, but the patient actually started chewing gum because they were trying to hide the movement.
Exactly. And, I had a patient who had some toe movements and had diabetes and was getting sores on their foot and had no idea that they were getting these sores because of their neuropathy. So it can really be life-altering to treat the TD and start these medications.
Absolutely. So, I hope the audience has enjoyed these comments, and I want to thank you, Rebecca, for participating with me in this. It's always great.
Thank you, John.
And again, thanks everybody for joining us.
Thank you very much, Dr. Kane and Dr. Roma, and thanks to you, the listeners, for joining us. As a reminder to view other programs on tardive dyskinesia, please click on the link in the show notes. As always, thank you for listening.